today about ocular motility and in particular neurological and mechanical strabismus. So I'll go through a little bit of basic concepts to who are not ophthalmologists, and then we'll talk about the conditions a bit more detailed as we go. As we mentioned, you can just drop us a couple of lines of questions if you have, and for your feedback at the end. So let's make a start. So what is strabismus? So essentially, squint or strabismus means the visual axis in both eyes is parallel. So the eyes are not, straight. One eye is either horizontally, vertically, or what we call torsionally. So one eye is twisted either outwards or inwards, and that causes, in some occasions, so functional strabismus, so the patient has a functional complaint, or a non-functional strabismus, i.e. the patient can see okay, one eye is out of position, but it's not causing them vision. We kind of try to avoid using the word cosmetic squint because it's essentially not a cosmetic problem. And basically what we can divide squint into a manifest squint. So you look at the patient and you see straight away that one eye is out of position, either horizontally or vertically, and we call that a tropia. Or a latent squint, you need to do something to make that squint appear. So the patient looks normal to you, but when you test on them, it becomes manifest. That's what we call so the patient has aphoria, so you look at them, there is nothing there, but you do some tests and then it becomes, and we can call it exophoria, esophoria. So exo means drifting outwards horizontally, eso means it's drifting inwards horizontally, hyper and hypo from their name, hyper is higher and hypo the eye is lower, and cyclotropy means that the eye is either twisted outwards or inwards. And as a differentiation, we can divide the squint into what we call a comitant squint and incomitant squint. And comitant squint means angle between the visual axis, the right and left, is usually the same or just about the same in various gazes, while incomitant squints means that angle changes as patient gaze from one position. And the focus of the talk today is essentially on the incomitant squint, although a couple of conditions that we will mention will have some element of concomitant squint. Concomitant squint usually happens in children, and it's general kind of common type that we in children. And the position of the eye from the ophthalmology point of view is divided into three positions. So the primary position where both eyes are looking. The secondary positions are the two horizontal positions, right and left, up and down positions, and the tertiary positions are the ones that in the diagonal, up and right, down and right, up and left, and down and left are the tertiary positions. And these help to understand kind of which muscle works in which position. So as you all know, we have 6 muscles, and these are, and they have 3 motor nerves. The first one obviously is the third nerve, and it feeds 4 of these 6. Then we have the lateral rectus muscle, which is fed by the lateral rectus muscle, which is fed by the superior oblique muscle, which is fed by the trochlear nerve or the 4th nerve. And the positions of the eye are governed muscles. So as you can see here, if you imagine that this picture depicts the patient in front of you, and this is the side of the patient, and if they're looking, for example, up and right, their right superior rectus, their equal work, and both eyes will go into that direction. On the example, if looking horizontally to the left, then the right middle rectus will contract to pull the right eye inward, and the left lateral rectus muscle will contract to pull the eye outwards. Are what we call the yoke muscles, so they work together, and they're governed by a couple of we'll mention in a minute. And in terms of names of eye movements, we call them vergence, so if the eyes are moving in the same direction together, or vergence if the eye in different directions. So one eye is moving this way and the other one is moving the other way. When we're reading, for example, our eyes come closer together to achieve the ability to read distances. There is no physiological condition where one eye goes up and one eye goes down. So the physiological vertical divergences. Inductions is a term that we use. I think I'm in one eye at a time. You know, we close the other eye and we assess the movement of the specifically. And as you know, we can term the eye movements in different directions. So elevation and depression, as from their name, a deduction, the eye is moving out. A deduction, the eye is excyclotorsion, the eye is twisting out. 12 o'clock is moving outwards, and in cyclotorsion, the 12 o'clock is twisting inwards. And these are the two laws that govern the eye movement. So the herring law means that yoke muscle will get exact amount of nerve feed to allow the eyes to move into the same direction at the same. And Sherington law means that when you feed, for example, the lateral rectus muscle, addition to the medial rectus muscle will happen to allow the eye to the muscle to relax and the eye to move in that direction. So the agonist of the contracting muscle relaxes. There is essentially basic types of eye movement, and these are the names of them. The saccades means it's the quick eye movement. So, for example, if I spot something, my eyes quickly into that position, and that's a saccade. We have the pursuit system, and linked to it the optokinetic system, and that means you're tracking slowly a moving object. So, for example, if you're seeing something moving in front of you, or you're tracking movement during the assessment, when you ask your patient to look from one side to the other and follow your target, then that's a pursuit. Divergence, as we said, is the movement into different directions. So one eye is moving right and the other one is moving left. And that, again, depends on, for example, if you're showing a patient something coming closer to them, so their eyes goes closer together. And if the subject is moving, their eye diverge. And the vestibular system is essentially eye movement that balance the head. When, for example, when you tilt one side, the eye needs to rotate to the other side to the vertical meridian, the same as it is tilt as we move up or up and down. You really need to understand that this is really a complex system, and in order to understand what's going on, very, very systematic in your approach, very precise in what you do, and you kind of, there's no shortcuts to this. You have to step at a time and understand what's happening. Usually is, first thing we say, observe how they're sitting, see whether they have a tilt, an abdominal head posture, for example, they're tilting their head to one side, chin up, chin down, these things. And then you need to do full orthoptic evaluation. Some of the steps that you do, for example, cover on cover test, where you're looking primarily at the primary position. So what happens to the eyes in the primary position if there is a manifest or a latent uncover when you're doing your cover on cover test, and you can measure that with prisms. And then you do so you ask the patient to move quickly from one target to the other, and then you need to do suits. So you ask them to move slowly. You can do the drum, and you kind of sometimes, especially in some of that we will discuss, you have to do a doll's eye maneuver. It's so you move patient's head while you're asking them on a target, and you see if their eye moves in different directions, and it helps create sort of nuclear and from supranuclear conditions for that matter as well. So basically, incommitants have neurological causes, you have mechanical causes, and you have other conditions. The neurological causes can be either nuclear, third nerve, fourth nerve, and sixth nerve, or it can be supranuclear, which are a bit more complex and a bit more difficult to understand. You have lots of common ones, and you have other conditions like Myasthenia Gravis and Miller-Fisher syndrome, etc. Supranuclear means that the innervation to the main nerves that feed the eye is inhibited, could cause a palsy that really affects both eyes, but it can affect one eye at a time. Usually symmetrical problems, i.e. both eyes continue to be ill, so patients don't complain of double vision, although they can't move their eyes in different directions, and we'll some of these examples. Despite the fact that they can't move their eyes in different directions, they still don't have double vision in some cases. However, in internuclear palsies, because it affects one eye more than the other, you still get the double vision in these cases. And as you can see from loads of centers in the brain are responsible for, some of them are responsible for the saccades, some of them are responsible for the pursuits, and that shows you the complexity of the system and why you need lots of investigations for these cases, and you end up needing to do neuroimaging to make sure you're not missing anything affecting these centers. So if we talk about the supranuclear palsies at the beginning, and we start with the vertical gaze palsies. So these are cases where patients can't move their eyes vertically, either one eye or both eyes, and there is three main structures in the brain that are responsible for gaze palsies: the interstitial nucleus of the MLF, the interstitial of Cajal or Cajal, and the posterior commissure. These centers are essentially for gaze palsies that are vertical in nature. Lots of causes, as you can see. That's why you're probably needing to neuroimage these patients, but essentially tumors, vascular causes, degenerative causes like progressive supranuclear palsy, disease, Parkinson's disease sometimes. Infection can cause as well. One of the commonest vertical nuclear gaze palsy is skew deviation, and skew deviation essentially, to make it very simple for even for us and as ophthalmologists, it's a vertical squint that is causing a nuclear problem rather than a third nerve palsy or a fourth nerve palsy. So its origin is higher than the nucleus of the third nerve or the fourth nerve, and it causes the disruption in the input into these nerves, and usually you end up with some torsion. It's really important to try to differentiate skew from there are several tests that you can do to do that. Examples would be that the nerve palsy, for example, the affected eye is usually higher, but also excyclotorting, while in the skew, higher eye or the hypertropic eye is encyclotorting, so the other way around to a fourth nerve palsy. Another test is what we call the upright supine. So you test the patient motility, upright position, sitting in front of you, and you see that the vertical deviation and the torsion is measured, and then you do the same test when they're on their back, on flat, and you measure the vertical deviation, you measure the torsion again. And usually in skew, because it's clear, you see that there becomes less. The cutoff point is usually about 50% less. In fourth nerve palsy, because it's nuclear or infranuclear, you don't get that change. Another example of the vertical palsy is the tilt reaction. So it's a triad of so you get deviation, you get torsion, so you get the torsion, the encyclotorsion usually, and you get a head tilt. So the patient kind of have that head tilt to try to maintain the vertical visual axis, and it's a disruption between the connections in the ears and the brainstem. Another example is a double elevator palsy. So it could be unilateral or could be bilateral, where the affected eye, if it's unilateral, cannot look up. So the patients in that eye, in primary position, they might be okay, or that eye might be a little bit hypertropic. But if it's parallel, they don't get any double vision. They only get double vision if they're looking up. It goes all the way. The other one doesn't go at all, and it's usually a supranuclear problem. Usually congenital, although there are a couple of forms that can be picked up from lesions in the midbrain. Double depressor is the reverse, so the affected eye cannot look down, usually congenital. There's something called the vertical 1.5 syndrome. So that means eye cannot look up and cannot look down, and the other eye cannot look up. So you have limitation of elevation in both eyes, and one eye limitation of depression. So the only reserved movement is a depression of the other eye. And it's kind of really difficult for that patient because they might be okay in primary position, but they look up, they can't look up, they look down, they get. So it kind of really troubles them, and it's difficult to manage. But usually it's a midbrain problem, and a supranuclear problem. Common name we'll kind of know is Parinaud or brain syndrome. And again, it's usually caused by a lesion in the dorsal midbrain from its name. And with this lesion of elevation, so patients cannot look up. When they're trying to look up, they get convergence retraction nystagmus, not a true nystagmus, but trying to look up, their eyes converge, they come closer. They get both eyes, so the lids are lifted upwards. You get sometimes skew deviation. You get pupillary problems, what we call a light near dissociation. So their pupil don't react properly to light, but reacts better to near. And also look up, they prefer a down gaze position. So their eyes are drifting downwards a little bit and their chin up. So they can get this, what we call sunsetting. So their eyes are a little bit lower than the horizontal midline. Progressive supranuclear palsy is a problem, a disease that affects the midbrain, and it causes lots of neurological symptoms described as you can see, but primarily from the eye point of view, it causes a vertical gaze palsy. Usually the down is affected more than the looking up in the beginning, at least. Eventually it has to affect both vertical and horizontal movements, but essentially the beginning of it, they cannot look down. And you get, although they might not get double vision, but they can't move their eyes downwards. So they have a chin down position to keep being up and down. A classical sign, what we call a round the houses sign. So when you look straight up or down, because they can't, they do that rotational movement. So they try to do a saccade, for example, or a gaze to up gaze. They can't move straight up. They go up, then they go up. So movement around the houses to try to see the target that you're showing to them. There are some signs to differentiate it from Parkinson's disease. So sometimes Parkinson's convergence inability, so they can't converge. It doesn't really palsy at the early stages anyway. That's the vertical. Palsies for the horizontal, they are a little bit more common, to be honest with you, and a little easier to understand as well. So usually there are two in the brain, or two collective centers in the brain that affects horizontal gaze palsies. There is a cerebral lobe centers, brainstem center, and depending on where the lesion is, the gaze palsy happens. So if it's in the cerebral hemisphere, then the gaze palsy is away from the side of the lesion, so the patient cannot look into that direction. And if it's in the brainstem, it's the same towards the gaze, so the patient cannot look towards that lesion. And again, it's the same concept, usually conjugate, so i.e. they are parallel, but they can't move in that direction or can't move in that direction. They don't have the double vision. Usually strokes, but in younger generation, you can get it from tumors, you can get it from multiple sclerosis and things like that. Some of the examples of the horizontal gaze palsies, the commonest thing is what we call internuclear ophthalmoplegia. It's something that we deal with quite a bit, where option to the MLF, and the MLF essentially is a nerve bundle between the sixth nerve and the third nerve in the midbrain. So a patient will not be able to look to the right because their right sixth nerve palsy and a left medial rectus weakness, so they can't move into that direction. and they get an abducting nystagmus. So that sorry, when you get an MLF lesion, you get a medial rectus weakness, and the lateral rectus in the other eye does an abducting nystagmus. I was describing the gaze palsy, but in the ophthalmoplegia, you get only the weakness. It's called by the name of the side that's affected, as you know. So this is an example of these conditions. You notice that the vertical, I didn't have any pictures. They're relatively rare to be able to pick them up, but the horizontals are a little bit more common. So hence the pictures, and probably a bit more interesting now. So guy, this is what gaze kind of slide, where this guy position, these up and down and right and left are the secondary positions, and these diagonal ones are the tertiary positions. So in primary, you can see he's relatively okay. Can look up normally, can look down normally, can look all the way to his left-hand side. Ask him to look to the right-hand side, right eye goes all the way, follow. So on this position, he will get double vision. Eyes now are not parallel anymore. But it's only that muscle that's affected, the medial rectus, because he can look up and he can look, it's not a third nerve palsy, it's only a medial rectus weakness in the left eye. Hence, it's a left INO. And if the clinic, he will have an abducting nystagmus in that eye. So that eye will beat several, it goes in that direction. Another example is what we call a horizontal syndrome. So that patient will not be able to move to the right hand side. The eye to look to the left, only they will go out. So the only preserved is an abducting in one eye. The other eye doesn't move right nor left, and the one eye that moves only to the abducting position cannot move to the position. And have here is a gaze palsy plus an INO. So you have a gaze palsy to prevent the right gaze, for example, and you have a left eye on top. And it's usually in the pons affecting these. You get a damage to the PPRF or the sixth nerve nucleus, and also an MLF lesion in the same side. Usually either strokes or demyelination in these patients. So this is an example, again, from the 9 gaze, that this guy looking straight ahead, he looks okay. He can look up, he can look down. When you ask him to look horizontally, so let's take him to, ask him to look to the right. So this picture is exactly the same as his right eye doesn't move, his left eye doesn't move. So he has an INO here, and he has a gaze palsy. This eye doesn't move. Ask him to look to the left. Again, the right eye doesn't move. So this is an INO here, but this one moves. So the only preserved movement horizontally is the abducting movement of the left eye. So 1.5 means he has gaze palsy and half gaze palsy to the left eye and a right INO. This is not complete, to be honest with you. The other thing that this guy has is facial nerve weakness. So you can see, for example, there is a little bit of lid laxity here. There is a little bit of ptosis or close his eye properly. He will not be able to do that. So he doesn't really strictly have 1.5 syndrome, what we call an 1.5 syndrome. And essentially, it's the 1.5 that we described plus palsy. If you remember your anatomy, you remember that the 7 fascicles wrap around the 6th nerve. So you get the 6th nerve nucleus damage, you get fascicular 7th nerve weakness, and you get the MLF damage, which causes the INO. So you get this, what we call 8 syndrome that we saw in this picture. Now some fancy ophthalmic kind of abbreviations. So WEBINO, or wall-eyed binocular INO. So you get a INO in both eyes. So that guy cannot look, his right eye cannot look to the left eye cannot look. And you get this feeling that there is something like a wall, and that's why we call it wall. There is a wall between the eyes, so this one does go this way, this one doesn't. Essentially, it's a problem in both MLFs. This is an example. This guy had bilateral INO from multiple sclerosis. He comes in a wheelchair, primary position. So light reflects in the middle. Ask him to look to the right-hand side. This one doesn't go. Ask him to look to the left-hand side. This one doesn't go. So he has this combination of adduction in both eyes, like a wall-eyed. Vertical movement, reasonably okay. Another one is WEBINO, so wall-eyed, but it's monocular INO. And it's to that one, but it's a little bit confusing. So they have monocular INO, so monocular lesion affecting the MLF, but they have a primary squint. So and you add onto it, so they have an exotropia, so their eyes are divergent. You add into it an INO, so they can't move, get this feeling of a limit of adduction in one eye. It's much rarer than the WEBINO that we described earlier, hence I didn't have a picture. Half and half is when you have a sixth nerve palsy, a pure sixth nerve palsy on one side, and MLF problem on the other side causing an INO. So you don't abducting nystagmus in the other eye because the eye doesn't move because of the sixth nerve. So you have half a gaze palsy, have half the INO makes the other half. And again, it's very similar to a gaze palsy, but usually you can differentiate of the neuroimaging where you can see where the lesion is. What we call a reverse INO or a posterior, it's exactly the reverse of the normal INO. So instead of having a limitation of adduction in the affected abducting nystagmus in the other eye, you get so that eye out, and this one is abducting nystagmus. It's not a very localizing because there is some variance, but usually it's around the sixth nerve nucleus. Quite common, quite rare. In fact, we only had a patient probably for the last 5 years, a few weeks ago. So that's supranuclear. So anything above the three cranial move the eye. So if we leave that alone and go down a little bit, motives that feed muscles, and there is three, there is the third nerve, and there's the fourth nerve, and there is the sixth nerve. Third nerve, which is the more kind of serious one, that feeds the medial rectus, superior rectus, and inferior. And because as kind of quick slide on the anatomy, midbrain, multiple subnuclei, then it goes out with the fascicles through some structures of the midbrain, so the red nucleus and the cerebrospinal tract. And it travels essentially between the superior cerebral artery, and that's it can be affected by the aneurysms, as you know, then travels through the cavernous sinus at the top there into the orbital cavity, and then it branches to different muscles. Third nerve is really an important one. It's involved in emergencies, and really need to be aware of these and quite quickly. It can be affected in giant cell arthritis. We've seen quite a few where they come with a typical PCA. They don't have any vision problems, but they have third nerve palsy. And you have to really be careful about these and pick it up rather than just assume it's nothing serious because there is no vision damage. The other emergency is, as you know, the posterior artery aneurysm. And you need to pick that up and investigate it and deal with it if it's there as soon as possible. So from the eye motility point of view, they have a limited elevation because they can't look up. The superior rectus is affected. They can't look down. Inferior rectus is affected. The left eye, for example, cannot go in of the medial rectus being affected or weakened. The only movement that they have is a lateral rectus movement. So they're out. It can be, textbooks would say it's out, down, but you don't always get that. It's usually out, but it can be a little bit up or a little bit down, depending on the balance between the superior rectus and the inferior rectus. You get ptosis because the levator muscle is also affected. And sometimes if it's, you get pupil involvement. Involvement means that that pupil is a little bit bigger than the other pupil. It can still be reactive to light. You have to be really careful about that, because we've seen patients who've been told, well, your pupil is reacting, so it's not aneurysm. Well, but bigger than the other one is enough to be its pupil, to say it's pupil involving. We kind of moved away a little bit now, especially in neuroophthalmology, from, you know, being and pupil involving. We tend to investigate all third nerves with an angiograph of some sort, depending on the local availability, but you can do either a CT angio or an angio. And then once you rule out the aneurysm and you rule out the GCA, the bloods, you know, the ESR and CRP, then you kind of calm down a little bit and then try to figure out what's exactly going on. But it's really a little bit dangerous to assume it's not aneurysm related in a patient just because it's not pupil involving. The chance, yes, it's 90% aneurysmal, but are you prepared to accept that 10% risk? Remember now, from the supranuclear ones to the nuclear or infranuclear ones, that eye movement, for example, doesn't work, because now you move you try to move the patient's head while they're fixed, cannot move because the nerve now is completely affected. It's not clear palsy anymore. So the Hess chart, and it essentially to the non-ophthalmologist, it just draws where the eye fixed different positions. For example, this guy has a right-sided third nerve palsy. So if you can see the left eye, the central position is okay. He's fixing that eye, but the right eye, is down and out. So his eye is down and out. He cannot move inwards at all, or a little bit. He has some elevated depression movement, but essentially can't inwards. And that third nerve palsy doesn't necessarily mean all the eye movement is eliminated. So you get palsy where it's affected but not completely eliminated. And this is an example. So you can see in primary position, this lady, left eye is okay, right eye is out compared to this one, and down, you can she's holding her lid because she has a ptosis. So when you ask her to look up, you ask her out, I'm missing this picture, but you ask her to look right hand side, she can do that. So the sixth nerve is preserved. However, when you ask her to look to the left eye goes, right eye doesn't go, because she has a medial rectus weakness. So superior rectus weakness, medial rectus weakness. When she's looking down, left eye goes, right eye doesn't go. So inferior rectus weakness and ptosis. So classical. Fourth nerve is a little bit less. Yes. So the bad one is the third. Remember that. The fourth and less. You still need to investigate them a bit less serious or urgent. And again, starts the midbrain. It's the only one that dissociates and goes from the backside of the it travels across between the circle of Willis vessels into the cavernous sinus, just under the into the orbit, and it feeds only one muscle, the superior, and that muscle takes the eye in and down. So left superior oblique takes the left eye down and in towards the nose, oblique down and in towards the nose. Most of these cases are congenital, acquired one usually after trauma, rarely aneurysms and tumors. I've seen some. In congenital ones, you still can get them in adults, but they are usually what we call decompensated ones. So ones that your brain has adapted to because they are congenital and from childhood, being able to control for most of your life, but then for a reason, some flu, cold, whatever, they're out of the compensation zone. They become a little bit manifest. They struggle a little bit with the dog to you for an assessment. And obviously it could be bilateral. And this is a Hess chart, as we said, about depicting these patients. This guy has got a bilateral palsy. So again, if you can see, so the beauty about this for non-ophthalmologists, it tells you which muscle is affected. So you can see here, so superior oblique muscle in the left eye is not functioning very well. So he can't move. This is the reference point. So the patient should be able to bring their eye to that position, but they can't because of the weakness in the left superior oblique. Less obvious weakness in the right superior oblique. So it's a little bit weakened compared to the left one, which is quite weakened. And you get what we call muscle sequelae in these patients. So you get an overactive inferior rectus muscle in the other eye. So go there, this one overshoots. Yeah, and go there, this one overshoots. And because the muscle is responsible not only pressing that eye, but also for a torsional movement of that eye. So it twists the eye inwards. When it's weakened, the eye twists outwards. So you get an excyclotorsion. And an example of looking for the excyclotorsion, you can do what we call a synoptophore measurement. But you can, the fundus examination in itself can show you excyclotorsion. You measure the relationship between the optic nerve and the macula or the fovea, and you see in the eye, the fovea is a little bit lower than it's, you know, higher. Both eyes are affected, as we can see, but usually it's the same, slightly lower. This one is significantly lower. So this is the fovea, while the optic nerve is much higher, and that eye is twisted outwards. And again, usually you depend on orthoptic assessment to figure out if it's long-standing or acute, because long-standing ones don't need to be investigated. It's a little bit beyond to talk about the signs of long-standing versus acute ones, but long-standing ones don't need to be investigated. If it's an acute one, the same principle of investigation, a little bit less acute compared to the third nerve, but you still need to do neuroimaging, you still need to do lots for them. This is an example. So this guy, primary looks reasonably okay. It's a little bit of a subtle one, but you can look at directions and you can see some subtle changes. For example, when he looks up, this one goes okay. This one dips under the lid. So this muscle, the inferior oblique muscle, is overacting here. Other side, if you look, this one goes okay or seems okay. This one doesn't really go all the way down. So his left inferior oblique, superior oblique, sorry, is underacting, while his inferior oblique, the antagonist muscle, is overacting, which is the muscle sequelae commonly seen in the fourth nerve palsies. So underacting, superior oblique, overacting, inferior oblique, and that kind of points you towards a left-sided fourth nerve palsy. And primary position, you could, the right eye is a little bit higher than the left position. When you ask them to look into the left, you can see it a lot more clearly, that's really drifting upwards. However, when you ask them to look down, okay, this one doesn't. If you look up, this one, okay. So usually fourth nerve palsy is manifest a lot more on the contralateral side. So right fourth nerve palsy affects primarily the left gazes, as you can see here. So right fourth nerve palsy, while the motility problem is essentially more in the left. As time goes on, and with muscle sequelae, changes can happen, but in acute ones, at least, you get this type of presentation. Sixth nerve palsy, pons. You remember we talked about the connections between different structures in the pons, and this is the nerve as it wraps around the nucleus of the third of the sixth, and then it's from here and through different structures and exits from the pons. It has a long path through and that's why it's a very noisy kind of nerve. So it comes from here, travels up, and then goes into the cavernous sinus. It's free in the cavernous sinus, so a bit more affected by changes in the cavernous sinus, and then it and feeds only the lateral rectus muscle. So that nerve is only responsible for the outward movement of that eye. It only produces horizontal double vision, doesn't cause any vertical element. This doesn't have any vertical function. So you get limitation of Same blood test. You have to remember, because it's very non-localizing blood pressure, you need to check the fundus, because we've seen so many patients with papilledema or raised intracranial pressure for what and has a sixth nerve palsy. So the key, at least in the sixth nerve, to check on the fundus and make sure there is nothing happening there. Again, usually end up neuroimaging these patients. A little bit acute, the third and the fourth are more common, and usually far more common, especially in patients who are or what's called vasculopath, so diabetic, hypertensive, things like that. You might want to wait a little bit for a few weeks. Then it's microvascular. If it doesn't improve, then obviously you need to investigate. Back to our pictures. Primary position. The weakness in the lateral rectus, they can usually end up with esotropia, so their eyes turn, but not necessarily in every patient. So for example, this is in primary position, she's okay. It's a very subtle one. Because we're talking about 6, we'll only focus on the horizontal movement. So you'll ask her to look all the way to the right, both eyes parallel, move all the way. Ask her to look to the left. Right eye goes all the way, left eye doesn't follow. It moves, but it doesn't completely go. Compare this. So where there's no white showing, while here you still have a little bit of the white sclera showing. So suggesting that this is the weakened lateral rectus in the left eye. As usual, in general for these patients, because majority of the nuclear ones complain of double vision, because really it affects the primary position, it affects motility in different ways, and it causes the parallelism of the eye to become abnormal. So they will get double vision, which can vary depending on the position and the position of the eye, being primary and secondary and tertiary positions. But in general, obviously you investigate them, you make sure that there is not. But if they are left with ocular motility after some period of motility, then you can offer them various options of treatment. Occlusion is basically an eye to get rid of the double vision. What prism? No, it can't move the eye, but it brings the images together. So we use vertical prisms, we use prisms. There is no prism, so there is nothing that to alleviate torsional double vision. We use Botox injections to try to, as you know, the muscles. In cases where you have an overact antagonist muscle, we inject that muscle to try to balance the action. So you have a weakened lateral rectus, for example, an overacting medial rectus, you inject the medial rectus to allow the deviation to become less obvious. Botox, as you know, has to be repeated. It doesn't last forever. Surgery, it's a little bit more complex. Again, depends on which muscle is affected and what's left. So the classical example is a third nerve palsy. Affects 4 of the 6 muscles. You're rid of your options, and you have to do lots of muscle transposition, remaining active muscles into different directions around you to allow to get some sort of movement to that eye. It's really difficult because in these cases, majority of the you need to be really counsel them and tell them that at best you're only going to get them single vision in primary position. They will always get double vision if different directions, but at least in primary position, if you make them double vision free, then they will be usually happy with that. So we call superior oblique muscle tuck, inferior oblique recession, Harada Ito procedure, and the ophthalmologist would know these. And we're stuck. Okay. There we go. So that's neurological. I'll show a couple of examples on the mechanical ones. And the mechanical, so we started right on top, supranuclear, the nuclear, and talking about the muscle itself. So things that are in the orbit that can affect the muscles themselves and cause an incomitant squint. And some of these examples is what we call Brown syndrome. So Brown is a problem in the superior oblique muscle. So that muscle the eye in and down, but essentially the superior oblique muscle is right in the trochlear region there. And when you have a problem, mechanical problem in that tendon, in that sheath, then you get limitation of that movement. And usually it's congenital, usually unilateral, but occasionally you get ones and occasionally you get acquired ones that can happen, you know, following trauma. We've seen it happening after dog bites. We've seen it after accidents, fractures to the orbit, things like that. You can get it from surgery. You can get it from inflammatory causes as well. And this is an example. This is an interesting one because he's congenital, but he's bilateral, which is relatively young. So in primary position is okay. The classical thing about Brown is although that eye, the superior oblique is affected, that eye classically, instead of not being able to, it cannot look up. So let's the left eye first. So primary position, okay. Forget about the down gaze. If we look at the up gaze, so when he's trying to look up and right eye goes all the way, left eye doesn't go. If he looks up and left eye goes all the way, right eye. So he has got a bilateral Brown where this eye cannot look in that direction. This go look in that direction. And the problem is in the sheath of the superior oblique muscle on both sides, it's getting that movement. And the way to deal with it, certainly if it's congenital, is by relaxing it, by doing either a tenotomy, so you cut it completely, or more commonly you do what we call a spacer. So you lengthen the tendon a little bit to allow that movement to happen. Either tenotomy or a spacer. But if it's a artery in a condition, for example, having trauma or following things like that, you might give them some inject with some steroids in that region to try to help with localized inflammation. Sometimes that works. Another example for mechanical conditions is thyroid eye disease, and as you know, lots of names. It's usually an autoimmune condition. Lots of soft tissue. They get the chemosis, the swelling on the cone, the puffy lids, but more importantly, at least from point of view, from the motility point of view, they get restrictions to the eye movements. Essentially, in the acute stage, you get swelling to the ocular muscles, and in the chronic stage, you get fibrosis in the ocular muscles. It doesn't move in certain directions. Usually, classically, in disease, they get limitation because the inferior recti are really affected, so they are becoming tight. They can't look upwards and look out. So they have limitation of abduction, limitation of elevation, because medial recti, inferior recti are the first ones to be affected. Usually, it's a severe and intends to cause vision damage, but you get 3 to 5% where it's really you get compression of nerve, and you need to deal with it with a little bit of urgency, and usually with steroids, IBM, to try to alleviate the pressure. What happens is because these muscles get larger, they squeeze them. So you get proptosis and you get corneal problems, but you get compression of the optic nerve because crowding at the orbital. And lots of classifications, as the ophthalmologist would know, for Graves' disease, this is what we call the no-spec classification, and it looks at the various signs. No spec, as it, or the classification, which is the clinical activity score, and the bottom three are the nasty ones. Proptosis, you get changes to visual acuity, and you get changes to the ocular motility, and that's when you have to really treat it a little bit more urgently. So a couple of pictures. This lady, they tell you that we're thyroid. Primary position, there is a proptosis, more obvious on the right, but even on the right side, there's a little bit of proptosis. You can see the scleral show here, which was more obvious here. You ask her to look up, left look up. You ask her to look out, left eye can't look out. So limitation of elevation, limitation of abduction. A little bit better on the right gaze because it's a little bit asymmetric. While down gaze, they're okay. So classically, these patients present to you with a chin-up position because they can't look up. They move their eyes down a little bit to allow them some movement. Another girl position, she's okay. You'll ask her to look up. She can't look up. in the left eye. Right eye goes all the way. You ask her to look out. As you can see, limitation of and a little bit of limitation of abduction on this eye. Significantly overacting left inferior. So when she looks down, it dips down under the lid compared to the right one. And this inferior rectus is very tight and pulling the eye too much while not allowing it to move upwards. For the thyroid ones, again, you kind of manage thyroid, you give them selenium, you ask them to stop smoking. In the emergency cases, you give them IVMP, intravenous methylprednisolone, especially when there is nerve compression or corneal problems. In the acute stages, usually either or prisms, but once they're into the non-active stage, when it's becoming fibrotic, obviously you can offer them surgery. But the sequence of the surgery, as we all know from the classical teaching, you do the compression first because motility, then you do motility affect lids, and then you do lids at the very end. And for the motility surgery, it's usually resection want to tighten a very tight muscle already. So you always release the tightness by doing recessions or weakening procedures for these muscles. Botox tend not to be very effective in these cases, but it can be used sometimes in the interim period. Another couple of examples of inflammatory condition, what we call an orbital inflammatory, and sometimes a little to differentiate this from a thyroid, but essentially this guy, unfortunately, for example, he cannot abduct, he cannot elevate. He also cannot depress his right eye, so it's limited in all directions apart from the medial rectus movement. So he can abduct his right eye, he can look inwards, but he can't do any other movement. So he's diplopic everywhere, essentially, apart perhaps from this. As you know, trauma, usually the orbital floor fractured, usually blunt trauma. We get them usually after being seen by Max Fax, and they either on them if there is a big, enophthalmos or double vision or entrapment of ocular muscles. But once the either the oculoplastics or the Max Fax colleagues has dealt with them, we kind of get them afterwards to deal with the motility problem. And essentially, you kind of look at what you can do to try either to free the muscle if it's entrapped, do muscle transpositions to allow the eye to move a little bit better in that direction. And this is a picture from one of our patients. So floor fracture, as you can see, inferior rectus is here, and it's dipping into the fractured area. So this guy will need plate to lift that area up. And then usually what you end up with, that plate to the muscle, so they get a tightness in the inferior rectus department, and when they try to look up, they can't move their eye up. Either try to free that muscle, scarring to the plate, or try to transpose to allow the eye to move upwards a little bit. Another example of problems, this lady, which had surgery recently, has a left orbital optic nerve meningioma, various limitation of movements. You can see there is a little bit of abduction, limitation of elevation, and downward she's okay. So again, all mechanical problems are usually similar in presentation. You get various difficulties looking in directions, but the key here is really knowing whether they had trauma, so it's fracture, whether they are thyroid, so it's thyroid eye disease, whether there is redness and pain, so it's inflammatory, or there is need to be scanned, and you get these tumor ones, for example. The last couple of ones are the mimickers, if you like. So the ones that mimic any of these presentations that we talked about, they can cause all sorts of things that can, Myasthenia Gravis. I've seen patients who present with a classical fourth nerve palsy turn to be myasthenic, third nerve palsy turns to be myasthenic. It really is to understand that it can mimic all these things. You need to see the variability in time. So you assess them and they're presenting in one way. A few weeks later, it's a completely different presentation, and that tells you something is happening. And the TSH receptor antibodies, however, in ocular myasthenia gravis, it's only positive in 50%. So it doesn't really give you the full picture, but it can help. The age population, usually young women or elderly men. Treatment, as you all know, usually either symptomatic with periodicity or immunosuppressive steroids or azathioprine. Thymus problem, we remove it. In very difficult cases and complex cases, plasma exchange or steroids, especially if there is bulbar myasthenia or generalized myasthenia. Another kind of mimicker or difficult one to pick up is Miller-Fisher, and it's a variant of Guillain-Barré syndrome, and an autoimmune condition causes. Usually the key marker here is the anti-GQ1B, where you get raised levels of these antibodies, but it can cause ophthalmoplegia that can be similar to a third nerve palsy, fourth nerve palsy, or sixth nerve palsy, but usually a combination of these. So when you get more than one cranial nerve palsy together, you have to remember that it could be this, and it really need to be investigated, and because usually treatment is either usually neurological. You either do a plasma exchange or intravenous IGs. Last one, CPEO, chronic progressive external ophthalmoplegia. This, you can see the face tells you they don't have any to their eyes. Essentially, the lid is kind of in both eyes. He can't look up. He have a little bit of downward movement. He can't move his eyes sideways. This one is a bit better than this one, but on the right gaze moves a little bit than this one. So multiple presentation, multiple limitation of movements. Usually the key here is its chronicity. So it happens really very slowly, and normally complain of double vision because it affects both eyes, usually symmetrically, so it doesn't really cause double vision. But sometimes they get a little bit out of balance. For example, this guy is exotropic, so he has vision. He ended up needing surgery to try to help with that. So really, I mean, sorry to bore you about this, but it's really complex. Get some optics if you have. They'll all need some investigations. It's really difficult to be able to diagnose them without doing anything, but get the orthoptics to have a look and look systematic orthoptic assessment and its stages. Do the blood tests, do the neuroimaging. In the vast majority of cases, I suspect. Be aware of the emergencies, usually strokes, tumors, CA, and aneurysms. And if you have a friend who can help, please ask them. Last picture, just to really sharpen everybody's mind. This guy, I saw him in clinic. He comes in, but he's got a mental health issues. But he's playing with a colleague of him, and that chap got angry with him and hit him with a. So the pen went through the left orbit, right here, traveled all the way to the back of his brain. Still alive, comes in, limitation of eye movement, can see well, vision is, it missed the optic nerve, damaged the medial rectus, structures as it goes along, and embedded the tip of the pen right at the back of his brain. Tells you something. There's some spare in there. Right, thank you all, and happy to try to answer any questions. Let's open the chat.
Thank you, Mr. Yagan. That was very nice. Good, nice, comprehensive ocular motility. We've got one question from Rashad Raza. Do you want to unmute and ask?
Of course. Thank you. Thanks for arranging this session and helpful. My question is more related to the discharge planning. We stuck in a many times when we see in the ward, once they are treated, they're coming with the with extraocular motor muscle palsies and stuff, secondary to the neurosurgical causes, and we end up keeping the patient for a few days, pause that seen in the in your clinic, and from that point of view, what do you say? I did not read through this that there is any major eye emergency conditions apart from just a few that need immediate
Yeah,
attention.
I totally agree. I think there is, from the eye movement point of view, once you're satisfied there is no urgency, you know, it's not an aneurysm, it's not a tumor, there is nothing else that needs to be there and then, you know, what we will do essentially, we either patch the eye or
Yeah.
give them a prism, and it can happen within a few days. With, you know, even on the ward, if they have a problem, just patch one of them to kind of manage the double vision that way. But essentially, there is no urgency behind it. Once we get these referrals relatively commonly, we're not going to operate on them anytime soon. We'll not be able to do anything drastic to them, actually symptom management, and that can be done either on the ward, or if you have the facility to get an orthoptist with a couple of days or something, they prism, but nothing else.
In terms of the reassurance and the rehabilitation, if I have to say, for example, reassure a patient, or in terms of recovery, do you have any in terms of percentage?
So
How percentage of the patient recover without uh, surgical input from your side?
yeah, so the commonest ones would be microvascular, for example. So microvascular nerve palsy, 6 nerve palsy, tend to be about 90% of cases. So
Oh,
90% would recover. It's a little bit different from in traumatic ones or post-surgical ones, because it all, whether the nerve is only traumatized or completely cut off. So
yeah.
that kind of really depends on sort of surgical procedure. If it's in patients who had meningiomas removed, removing the meningioma to damage or sacrifice the fourth nerve, for example, because it was closely attached to the meningioma. In these cases, recovery becomes a little obvious. But nonetheless, they can evolve over time, and usually some of them adapt to the double vision without doing anything, you know, surgical or otherwise. But in microvascular, it's commonly about 80–90% would recover nicely without any whatsoever. And that's why we don't touch them 6 months later anyway.
All right. So does it mean that 6 months, giving a time frame of at least around 6 months?
Yeah, before any surgical intervention, we don't touch them until 6 months passed from the onset of whatever they had.
Okay. Okay. Thank you. So yeah, it was these days. I'm working with the Vasco. We see quite a few patients having them. So thanks a
Yeah,
lot.
no, pleasure.
Thank you.
So the next one, what's the selenium? Well, I'm not a thyroid eye specialist, to be honest with you. I tend to deal with the squint after the thyroid eye disease. My understanding is given right at the onset, whenever they're diagnosed with thyroid, they get selenium prescribed, and they get the advice of stopping smoking straight away to try to minimize the chances of further, you know, ocular involvement and further scarring to the ocular muscles. Yeah, so that's your question about the time frame. Any comments about buckling? Well, I think fortunately it's less and less common these days, as you guys are not doing buckling anymore, and well, you're doing compared to you know, vitrectomies. I started about 10 years ago. There was lots of buckle related sort of double vision. Now it's getting common. The usual suggestion is we see them, we make sure it's stable, it's not changing over time, and then we look at whether the buckle can be safely removed or not. And in my experience, that even if you remove the buckle, there is a muscle scarring and muscle damage that even if you remove the buckle, that in itself doesn't really solve the problem completely. So, but we say if we can remove the buckle, we do it, and we address symptoms depending on what muscles are damaged and whether we can either, interestingly, for example, in some of these patients, you get limitation of movement in the buckled eye, but because you can't really repair that for whatever reason, sometimes you patient surgery on the other eye to match the weakness. So, for example, if they can't their right eye out, we offer them surgery in the movement of the other eye in that direction. Classical example, I had a patient a few weeks ago where she had a buckle and she couldn't tie myope. She had a buckle, superior rectus that eye. She can't look up. She vision. We thought we can't of that eye because ophthalmic and seemed a bit scarred. So we offered her surgery to the other eye to stop her from looking up as well. So when essentially what we're trying to do is to get the balance, as we said at the very beginning, it's the parallel visual axis what you're looking for. If she can't look up in both eyes, then the double vision will be. But imagine asking a patient who's had surgery in one eye and she feels that there was a problem in one eye that you're on the other eye. So she was a little bit reluctant about that. But one of the examples that what we can do. There's a fourth nerve and sixth nerve palsies, for example, in a diabetic patient. Will you wait for a few months or do neuroimaging regardless of the factors? So if it's an isolated 6 or an isolated 4, let's take them one by one. If it's an isolated 4th, I want to make sure it's not congenital that decompensated. It's an acute one. In my opinion, my personal opinion, I'd prefer to scan them sooner rather than later. But you can say that you can wait months. You can wait for 4 to 6 weeks. If it doesn't show any signs of, then you have to scan them. And the same applies for a 6th nerve palsy. Probably a little bit more safe with a 6th nerve palsy. In a diabetic hypertensive patient, you can probably wait weeks. If they are showing signs of improvement, leave it, microvascular. If it's not improvement, you scan them months. You have to be a little bit vigilant about it. A combination of the two together, I'd scan them straight away.
When you say scan them straight away, do you mean CT, MR?
Tricky question. I think to some extent it depends on how suspicious you are of them, and the age and what's going on, and sort of access to the neuroimaging facilities that you have. So I've seen patients who present to the eye emergency clinic, patient in their 30s, 40s, no risk factors, palsy. In my mind, if I can get an MR scan within a week, I'd be happy with that. But if the neuroimaging guys would say to me, the next time I can squeeze her in is about 6 weeks later, then I'll see today, and then I'll wait for the MR scan. Probably CT wouldn't show me anything, but I'm trying to rule out a tumor there. So I rule out a tumor with a CT, then I wait. It's probably an MS related, for example, or something, which will not show on the CT, but will show on the MRI scan. So it depends on how soon you can get the MRI scan. My preference, as you'd expect, is an MRI scan. But if I can get it within a week, I'd settle down for a CT now and then MR later on.
I think that's all the questions, unless I can ask anything to conclude.
Dead silence. Bored everybody to death.
I think that's enough.
Thank you for the attendance and for your for the invite again.
Thank you again.
Cheers.